Okay, great. Am I showing the right one?
I'm seeing a picture of my dog and a pumpkin.
Okay, perfect. Great. So, welcome everybody to this Friday's CFAR ATEC conference. We're really excited to have with us a special guest, Dr. Paul Sachs. So I think many of you will probably recognize him from this type of a source. So this is the Paul Sachs Twitter account, which you should follow for erudite observations about infectious disease, both HIV and general ID, occasionally some bragging posts, like when he got his certificate of completion for disinfection wipes and received the Nobel Prize on the post. But in addition to this position in our zeitgeist socially, he's also the clinical director of infectious disease at the Brigham, and really most impactfully for me and many others, the director of the HIV program and the HIV fellowship program, which now I think for more than 30 years, because I think this picture was the 25th year celebration, has provided expert multidisciplinary care to people living with HIV at the Brigham, and has trained so many people who are just absolutely thrilled to come back any chance they have to spend time with Paul and to remember that year. So I was fortunate enough to have Paul take a risk on me despite my basic science detractions, and was now more than a decade ago the HIV fellow, and just learned so much from people living with HIV that year, and from Paul, and also from the way that he chose to deliver care, which involved that's me like hovering over his shoulder in this picture. We had a weekly meeting on Wednesdays where everyone would bring their own lunch, and then one of us would be responsible for dessert. And like my first week as an HIV fellow, I was like, okay, so what's the point of this meeting? And Paul was like, the point of this meeting is to talk about our patients, whether it's clinical questions or just patients who are challenging us in personal or social ways. And that is the kind of care that is just like an absolute joy to participate in. And then I've just put here, for any of you who follow Paul's blog on Journal Watch, the New England Journal, he also has lots of erudite observations on that, and does these linkoramas where you can link to all these important papers about various different things. And so these are just two other papers that I think are really great that Paul has done in the past. One of them, an interview with a physician with hemophilia and his experience living with HIV, and the other one, a personal story from him and his wife that was in JAMA 2 years ago. So with that, I will stop sharing and say thank you so much for joining us, and excited to hear about what you think is the future of HIV and primary care.
Okay, thank you, Eileen. It is for that incredibly nice introduction, and it's a real tremendous honor to be here. I'm going to tell you that what I'm going to share is some thoughts about HIV care, and in particular about ID specialists and our role in it, because my thoughts on this have really changed recently, and I'm going to try and explain why. And because I'm talking to a group of infectious disease doctors and a group of people interested in HIV, understandably, I'm very interested in hearing your views. So periodically I might stop and ask things, and I'm hopeful that there will be some participation as we go along. So I will now start sharing my screen and see if I can do this again. And I ask, can you see the slides? Great. As part of CME accreditation, I need to share my disclosures. I realize there is no CME for this. The whole process of obtaining CME at academic medical centers has become Byzantine, to say the least, and it's not for lack of trying. Eileen did try, as did I, so I apologize to those of you who are here just for the CME credits. So let me take us through some historical aspects of this, and for those of you who are of a certain age, meaning my age, you'll remember each of these phases. We're going to start with the fact that I first started discussing this issue in the early 1990s, and I contacted two of my cohort from a clinical research course that I took in 1991, and I said, Greg and Elaine, if my memory is correct, you two did a project in 1991 on the topic of who should be doing HIV care, specialist or primary care. Is that correct? And if so, did anything ever come of it? Believe it or not, this topic is still being debated. all these years later, someone has asked me to give a talk on it. Would love to cite something ancient that shows how long we've been doing this. So they got back to me and said, I don't think anything came of the idea, but Elaine may know. And glad you reached out. Incredible this is still debated. It is still being debated. And it is debated because things have really changed. And I want to just start with the era that actually overlapped with my residency, which was an era where we really didn't have much in the way of HIV treatment at all. We did have a lot of opportunistic infection prophylaxis. And in fact, I remember very clearly Dick Chasen being the first person really to say these macrolide antibiotics are pretty active against M-avium complex and how exciting that was. We monitored CD4 cell counts. We didn't monitor HIV viral loads because they were not available yet. And we did have nucleoside reverse transcriptase inhibitors, and they had some effectiveness, but not very much. So a lot of what we did was, at least toward the end of people's lives, was palliative and hospice care. And my Boston colleague, Deborah Cotton, wrote a piece in 1988, basically saying, no specialty has all the skills to care for people with HIV, especially ID doctors. Fewer than 2,500 board-certified ID doctors. And she wrote, the projections over the next 5 years dictate that general internists maintain their role as primary providers for patients with AIDS, but they will need to support the support of AIDS specialists to provide appropriate care. And actually, when you go back to that era, most ID doctors were doing pretty much only hospital-based care. Very few were doing outpatient care. Some, not all, did not want primary responsibility for the outpatient care of people with HIV. The disease had a poor prognosis and was highly stigmatized. I have to say, John Bartlett was really revolutionary in this. He was an ID physician, already well-respected, and he took the lead. He said, we should be doing this. And I got to give him credit for that, and I still miss him to this day. Some ID doctors, including one I worked with here in Boston, said, look, we don't have much to offer. There aren't many treatments. So our specialty services really are only necessary when the patients are hospitalized. And that is when they get opportunistic infections. So wait until they come into the hospital, and then we can care for them. But otherwise, their outpatient care should be done by their primary internists. And so because of this gap, a mixed group of people kind of took over HIV primary care. It included ID doctors, some included people in internal medicine, some famous ones like people like Cal Cohn, who's now works for Gilead, and he's never trained in ID. And another person who comes to mind is Ken Friedberg, who is a clinical researcher I work with here at Harvard. Family practice, other medical specialties, nursing, and pharmacy. And it's sort of a ragtag group. There are some subspecialists who did it as well, some oncologists, some dermatologists, some rheumatologists, but there was no HIV specialty. So that sad era ended, fortunately, in 1996. We had combination antiretroviral therapy. It was extremely complex and toxic. HIV viral load testing arrived right around the same time. It allows me to show this slide. I love to show this slide, especially when there are younger people who are watching me give this talk, because I can explain to them that these things, these shiny things, are magazines. And that's kind of how we used to get our news. But 1996, both Magic Johnson and David Ho appeared on the covers of our two major news magazines, really outlining what was an extraordinary advance in HIV treatment, which is we now could treat it. Amazing. It was a miracle. But it was not easy. It was not easy. So I'm going to just show you a typical regimen. This one was 27 pills. If you add to this, you had to continue opportunistic infection prophylaxis and also various treatments for amelioration of medication side effects. And then there was also a dizzying array of drug interactions that were occurring, especially with the protease inhibitor class. And so I'm now going to put you to the test. Go ahead and look at the pills and tell me, what was the regimen and how was it given? And does anyone actually know And I'm going to look at the chart and see if anyone is going to get it. So far, I don't think anyone has come up with it. Do we have any old timers in the audience who want to weigh in? You can see that it is triple therapy. There are 3 different type of pills there. We've got zidovudine, Fortovase, and Hivid. Excellent, excellent. The person who just put gets full credit. That's what this is. So including use of a now defunct generic. Okay, this was Sequinavir soft gel, 6 capsules 3 times a day with food, otherwise known as Fortovase. Zidovudine, which has 3 names, as you know, 2 capsules 3 times a day, and zalcitabine, 1 tablet 3 times a day. It was a horrendous regimen, and 2 of these 3 drugs are no longer available. So treatment got so complicated that there was really this thought, well, can we really still have people in general internal medicine do this? Because they can't keep up with these advances. And so there was an alternative view put forth in JAMA. And this is written by Abby Zuger and colleague. Abby is an ID doctor from New York City and an extremely good writer, by the way. And she wrote, bisecting HIV disease into the simple asymptomatic stage managed by the PCP and the complex symptomatic stage requiring specialty consultation has become virtually obsolete. And indeed, this was a very tough thing for people to pick up. And it led to this now classic paper. This is from a place you might recognize. And in case you don't, I put a very important signal in the upper right part of this slide. This is 273 people starting triple therapy in an urban clinic in Baltimore that you might recognize. And the virologic suppression at 1 year was 37%. And a lot of people didn't come back for their care. And the quote here, the key quote is, unselected patients in whom heart is started in a clinic setting achieve viral suppression substantially less frequently than do patients in controlled clinical trials. And for years, this study was cited as a reason to defer starting antiretroviral therapy. And let me pause there now again and see whether anyone wants to comment about the study. Is there anyone on this talk who has participated in this study way back when and wants to share what it was like doing it? I don't know if there's anyone who can unmute themselves or if any of these 3 Hopkins faculty are present.
I see Richard Moore.
All right. Let's see if Richard Moore wants to comment.
Yeah, Paul, thank you. This was an interesting study to do. It was actually a difficult study to do, but I think it was accurate in regard to what was going on at the time. And I think the fact that it ended up being used as a reason to defer ART is unfortunate, because that was really not at all our purpose in publishing this. It was actually, in some respects, a wonderful finding that we went from essentially 0% to 37%.
Yeah.
So
excellent perspective. And I have to say, what I was really appreciated was that you and with John Bartlett updated this later and showed that it was now up from the 80 to 90% range. Okay, so moving on, we're now going to go to the next era, and the next era is era 3. And here we have kind of a little bit of the pendulum swinging in the other direction. We're seeing lots of toxicity. We get this when to start debate. We have the whole fad of treatment interruptions, most notably, I think, in the 2001 Durban AIDS conference, when the plenary talk by Tony Fauci was about all the treatment interruptions that he was doing in his NIH research unit. And then we also had this thing with like people with taking their medicines exactly as directed and yet still viremic, usually because they had nucleoside resistance to start or the PK of the protease inhibitors was not very good. And so we had tons of people getting resistance genotypes. And I remember hearing from a very dedicated primary care doctor who said to me, Paul, I'm happy to keep following my patients with HIV as their PC, but I'm never, and I mean never, going to memorize all those resistance mutations. Sorry about that, says Howard. This is a typical picture from that era. You know, this person has both lipoatrophy of his face and a dorsocervical fat accumulation. And this would be a typical resistance profile from that period with multi-class resistance, sometimes happening in people whose CD4s were pretty high, and yet because they couldn't achieve viral suppression, they developed multi-class resistance. So that led to studies like this one. And this is a typical study. This is done by Pablo Tebas. I think he was at the Wash U at the time, but he's now at Penn. And it's basically a prospective study who just people who stop treatment, you know, and their CD4s drift down, not surprisingly. And, the conclusion is that you can do this. And there are a lot of pretty smart people who are making the argument that, we're being too aggressive with our treatment. Well, things changed, fortunately, and this is one of the, I think, unheralded great advances of HIV therapy, which is the first integrase inhibitor, which is raltegravir. And suddenly, everyone who is prescribed ART and takes it, almost everyone is virologically suppressed. It was during this period that people who had never had an undetectable viral load before suddenly did. And then we also started seeing our first treatment as prevention studies. And hooray, this was the period when Eileen Scully was an ID fellow here. And so Eileen, I wanted maybe you could reflect on what it was like during this period, if you had any recollection.
So I do. I remember so much, and I remember we had a few patients, one of whom was desperately waiting for a hip replacement until she could get suppressed, and then she was able to become suppressed. And then for me, then the real was Viking 3 and the approval of dolutegravir, which occurred during my training and was a transformative time.
All right. Well, anyway, this is a very exciting time. And I think this is one of the more extraordinary studies. It was done in France, and essentially in the ANRS got a grant from these three companies who made raltegravir, etravirine, and darunavir, and said, we're going to give all three of these drugs to our patients with resistance and viremia. And look at that, 90% virologic suppression. The first time I saw these data, I really couldn't believe it when it was presented at a conference. In hindsight, it's not so surprising. Darunavir was developed specifically for drug-resistant virus, and so was etravirine. And raltegravir was a completely new drug class. So, in hindsight, these patients who were very adherent and had resistance to multiple complex drugs because of the fact that they never got such potent and effective therapy before, now their adherence really could play a role and get them suppressed. So, hooray for TRIO study, single-arm study, and everyone started to experience the same thing in their clinics. Steve Deeks tells a funny story how, he's another person, by the way, who didn't train in ID, but he's such a brilliant person that he always was interested in HIV and became the de facto resistance expert in their clinic. And everyone would come to him for advice about what to do with their patients. And he said, after 2007, it was easy. He says, you just basically put them all on darunavir, etravirine, and raltegravir, and they'll get suppressed. So very exciting period. I also should mention that we now knew that everybody with HIV should be on treatment. This was, of course, the HPTN 052 study, and I do want to give a shout out to the ACDG, which also collaborated in this trial, but hasn't gotten very much credit for it. This study basically showed that if you're on treatment, you don't transmit and virologically suppressed, you don't transmit the virus to others. So it led to the next era, which is basically everyone takes ART. It was before the START study. It was actually, it was interesting when I was talking to my European colleagues at the time. Once HPTN 052 came out, I said, I can't imagine that the START study is going to be able to continue. And they said to me, oh, no, we still have people who aren't sure they want to go on ART. And it just maybe showed a big difference between the clinical philosophy of the the doctors in the United States versus Europe or the patients or something. It was just very, very surprising to me. It turns out that the START study mostly enrolled in the United States in centers where there was actually difficulty accessing medications. And that was the primary reasons why people enrolled in START in the United States. But once HBTN 052 came out and people knew that on treatment they wouldn't transmit the virus, there was a lot of interest in going on therapy. But of course, the START study did come soon thereafter, and we knew that going on therapy, even for people with high CD4s, is going to be incredibly important for the maintenance of health. I thought it was fascinating. The New England Journal of Medicine just published a follow-up of this study showing that the benefits accrued by starting right away in this population have continued for years, that group who started ART early on is still doing better than the group who deferred, even if the group that deferred eventually got their CD4 cell counts to some reasonable level, but never quite as high. So I'm going to ask Eileen, because she's an immunologist and as well as an IT doctor, if you can explain this to me. I mean, what is there a subclinical immunodeficiency we don't know about for these high CD4 people? What's going on? Why is there such a long-lasting benefit?
It's a good question, and one that would really, I mean, the only way you could really address that is if you looked for the diversity of T cells and to see whether or not you still retain your ability to recognize all things, or if you see more immune exhaustion or some of these other softer markers. But it's surprising because in general, those things don't have hard clinical endpoint correlations. They are more the things that we get excited about in the lab, but that then are harder to translate into a finding for patients.
Yeah. I mean, it's clearly beneficial, even though we couldn't see it in the clinic, that someone who starts with a CD4 of 600 is healthier than someone who starts with a CD4 of 400. You just couldn't tell, but that clearly is shown in the START study. And the other thing, and Eileen, the follow-up of the HBTN 052 were these cohort studies where people who were actually, enrolled specifically because they're having condomless sex and they're in discordant relationships. They're enrolled in these cohorts and no transmission seen so far in any of these cohorts. It's really remarkable, which has, of course, given us more impetus to treat everybody. Now, I do want to not leave the people with drug resistance behind, but I will say that there is a tremendous paucity of people who are going on our newer drugs, if like you count newer, ipilimumab, fostemsavir, lenacapavir. And the reason why is because when you look at the people in treatment in the United States, and this is from the CNIX cohort, this is 27,000 people who are treatment experienced. And then if you define limited treatment options as having 2 or fewer available classes with 2 or fewer active drugs, less than 1% of people are in this category. And that's not counting ipilimumab, fostemsavir, and lenacapavir. And not only that, that group, 80% of them are virologically suppressed. And this has to do with I believe, dolutegravir and bictegravir, which have such astounding potency and barrier to resistance that even when the rest of the treatment is kind of, not so great, they're able to maintain virologic suppression. So it's a really exciting time for HIV treatment. We're in the best treatment era we've ever been in by far. So this has come in exchange for taking care of older people with HIV. And if you're an older HIV doctor like me, and you've been following patients since the early 90s, your patients have gotten old with you. And not surprisingly, they picked up all kinds of comorbidities. And I just chose this English cohort study of nearly 5,000 people with HIV. And over time, the number of comorbidities steadily increases as patients get older and older and older. And this is the reality of HIV care today. And it allows me to share this important slide. This is a slide I put together using this XKCD comic. And if I could, Eileen, if I could ask you to read the titles of these papers, do you mind?
So we have switching suppressed people with HIV on ART to almost anything maintains viral suppression is the title of the first one. Older people with HIV have more comorbid medical problems. Yes, aging sucks for everyone. Here are a bunch of abnormal cytokines that no one measures in clinical practice. Low level viremia drives us crazy, so we studied it, but you still won't know what to do. Another unsuccessful broadly neutralizing antibody study, but this won't keep us from trying with something else. Some phylogenetic trees and or SNPs you don't understand. Poor adherence to PrEP is associated with getting HIV, as if we needed a study to prove this. And do some people with HIV were diagnosed late because the clinicians caring for them for months somehow never sent an HIV test. This HIV cure intervention using drugs you've never heard of looks really promising in a mouse. The curves in this randomized clinical trial of an HIV vaccine overlap with depressing precision. Yes, and no, we still I haven't found a good use for Maraviroc. And here's a new resistance mutation that you will need to memorize.
Thank you. I really appreciate that. I'm taking my authority as your previous clinical mentor to put you through reading that. I will say that the reason why I'm sharing this with you is to highlight this one, because that is exactly what's going on in HIV clinics today. And so Jules has been an HIV activist for years, and he is in charge of the NATAP site, and he writes on Twitter, he goes, 70% of people with HIV in New York and San Francisco are over 50, 300,000 in the USA are over 60, soon 70% will be over 70. We don't have a care system that meets the needs of our elderly people with HIV. Our $1 bill Right Work Care Act must be reconfigured for them. So this is saying that it's not meeting his needs, it's not meeting our patients' needs. He chose Raj Gandhi, Mike Sag, Carlos Del Rio, me, and John Lee. I thought that's an interesting group to call out. I wish I had effect on policy. And here he's quoted in Positively Aware, it's the #1 problem that's getting no attention. Everyone's talking about cure and PrEP, and they're all important, but no one paying attention to aging. So what does that mean for our clinic? Well, essentially all of our patients scheduled to see us are suppressed. They're virologically suppressed. Most have primary concerns or medical problems that are not related either to HIV or to ID. There's lots of focus on prevention. I suppose you could say the vaccinations are ID related. They are, but that's something that primary care does very well. Cancer screening and STI screening. The STI screening is very relevant for some of our patients and less so for others. An increasing number of HIV age-related comorbidities and very few decisions regarding antiretroviral therapy or OI management. So I guess now is a point I'm going to ask, what does the literature show on this? What are the right metrics of quality on who should be doing this care? Well, I start with the primary care guidance that was published in 2020. You'll note that a lot of the people on this are ID doctors, but what you sense when you read this is that most of the primary care for people with HIV it's now very similar to those without HIV. And I want to emphasize that some of the highest quality care given to our patients now are done by nurses and by social workers and by pharmacists. And one thing that there's a tremendous data gap is studies evaluating the quality of care right now in the most recent treatment era, the era 5, where, the dolutegravir, bictegravir era, where everyone is suppressed, who's doing it the best? I'm going to show you what data we have historically, because it's interesting. Back in the pre-ART era, this study got a lot of attention. This is Mari Kitahara from University of Washington, looking at mortality. That's a scary endpoint for people with HIV. This is before we had antiretroviral therapy, and categorizing people's practices based on volume. But look at the volume numbers, 1, 2 to 5, and 5, and yet this was a significant effect seen, even with these tiny, tiny numbers. If you go on to more recent data, these are data that were done by a group at Tufts and at Brown, looking at the care given by general medicine and some people who were expert generalists. They categorized themselves as, I'm an HIV specialist, but I have a primary care, general internal medicine, or family practitioner background. And the volume again really showed that it was predominantly the most important factor. Clinicians with fewer patients had significantly lower quality measures. When you look at the quality measures, though, they don't really apply today. Like, is someone receiving pneumocystis prophylaxis is not really a relevant quality metric any longer for most people in care. Sticking with this era is this looking at the care given by non-physicians. And again, there was really no difference in the quality of care. And one of the nurses who I've written about this says every HIV patient should have an ID doc watching their care, but for routine and general health care, they really need a good nurse practitioner who could spend the time necessary and be easily available to meet all their needs. And then because I always like to quote Rafi Landovitz, who's another graduate of our HIV fellowship, he surprisingly published this paper, has nothing to do with PrEP, because I think like 99% of his academic output has to do with PrEP. And it is looking at people in the government-funded, Medi-Cal program in California. And again, finding that people who were seeing more patients were more likely to provide better quality care. Now, notes the dates. This is 2009, 2010, even though the paper was published in 2016. So again, we do not have any recent data on this question. So to conclude from these studies, I would say, the key determinants of quality of care are experience, volume, and interest. And these seem to be more important than specialty or degree. And one person commenting said, I believe we should be asking and answering this question from the patient's perspective, not from our ownership perspective. I'm a primary care doctor. All my patients, including my HIV positive patients, voice their desire and appreciation for comprehensive whole person care. If an ID physician is ready and able to truly perform these and many more functions as a true primary care physician, then by all means, they may do so. So at this point, I'm going to present 3 cases, and then I'll leave it open to you and say who should be providing the primary care. The first case is a 31-year-old woman who was brought to the hospital by family with seizures, and she's lethargic, and she's got several, on imaging, several ring-enhancing lesions, including this very funny-looking one in her right occipital lobe, and she's increasingly weak over the last several months, and her HIV test is positive. This is a new diagnosis. Her CD4 cell count's 10, her viral load is 140,000, and she has a diagnosis of CNS toxo confirmed by PCR. The next case is a 48-year-old man who decides to transfer his care to your practice from another city. And not only did he have the wherewithal to schedule this ahead of time, but he had all the records sent ahead for your review. And 5 years ago, he was diagnosed in his early 40s. His baseline CD4 was 510, viral load was 5,000, no resistance or viral hepatitis. He goes on ART, rapidly achieves viral suppression. He has no other medical problems. He's on bictegravir, TAF. All his immunizations and screenings are up to date. He works in consulting. He's married to his male partner, and he's has no questions or interests. He just needs them to give him care, and his exam is normal. Okay. And then the last is a 72-year-old man diagnosed in 1992, and his initial CD4 cell count was normal, but he then went on treatment in 1997 when it fell to 290. His first regimen was stavudine, lamivudine, and nelfinavir, a regimen we would never use today. A lot of mitochondrial toxicities because he got lipoatrophy and neuropathy, and then switched ART multiple times, but never had treatment failure or HIV-related infections. And he's currently just on dolutegravir, lamivudine with viral suppression. But this is a 2-slide presentation because he falls into this category of the accelerated aging phenotype. He's got chronic renal disease, hyperlipidemia, hypertension, diabetes, CAD, compression fractures, hepatic steatosis, reflux. He smoked previously, but doesn't smoke anymore. And aside from this 1-pill ART that he's taking, he's on 15 non-ART medications. He can walk only a very short distance. and he had to retire from work at age 60 because of chronic pain and fatigue. So there are your three cases, and I'm going to again call on the group. Maybe I'll briefly even stop sharing and see if anyone wants to weigh in on who should be doing the primary care of these cases. It's not easy.
So maybe I'll just see if Joyce is the director of our clinic and is, I think, best described as an expert generalist, and actually has led a lot of initiatives in our clinic to have us be the Maryland primary care physician for people who we are functionally their primary care. I don't know, Joyce, do you want to comment?
Yeah, sure. Hi, Paul. I have seen you, and I think Eileen introduced us once a few years ago at Croy. So nice to see you again.
Nice to see you.
Thank you for the excellent talk. And
Not
all
done.
of your... Oh, okay. This is like an intermission, and then there's more.
You got it.
More talk. Okay, so I won't take too long. So, my background is I did a primary care internal medicine residency at Columbia, and I was mentored to do HIV care by Karen Brudney, Jay Dobkins, Scott Hammer, and my real interest was in working with underserved populations, and I really gravitated to the HIV group. So did not do an ID fellowship, have, finished my residency back in 2004. So always have worked in HIV. And I really agree with the last comment that experience, volume, and interest, right? Arguably this third patient, I think really expert internal medicine primary care is what that gentleman deserves. Geriatric care. We have a geriatrics specialist in our clinic for that very reason, recognizing that for our aging patients, we need that extra expertise. So from my perspective, I think that ID, general internal medicine, nurse practitioners, whoever has the experience, volume, and interest to work together. The other comment I would make is I'm finding more that having an interest in care coordination is very important. So to really address those psychosocial issues, we're often wanting to look to other disciplines to care coordinate, but really, our expertise in the field with our patients, we know best how we need to prioritize some of these things. So being willing to be a quarterback to lead the team, I think, is another important piece. And so people who don't just want to sit and think about the medical pieces, but want to really think about the whole patient, I think that's another very important part.
Thank you. I completely agree. You have the ideal training to do HIV care in 2023.
Thank you.
Another commenter.
Sure. Hi, Paul. It's Jason Farley, a nurse practitioner in our clinic and the director of our AIDS Education and Training Center, which I inherited from John Bartlett as a PI when he decided to step away from AETC. We've been training primary care clinicians in case 2 and increasingly case 3 for more than 15 years now. So I really agree with Joyce. Resonate strongly on case 2 and case 3 being internal medicine primary care, including APRNs and PAs. With case 1, I would say most of our general primary care folks from an AETC perspective would run to the, quickly away from case 1, and most would not feel comfortable doing that. But just agreed with Joyce and wanted to weigh in on.
Right.
We've been doing that for a couple of decades now with case 2 and 3.
Excellent. Thank you for your model. That's really helpful. I'm just going to quickly look at the chat. Ryan White funding is critical. And the comment is it's not available to general primary care clinics, and I agree with Amanda. So let me just share with you what just recently happened. I decided, since it's been 9 years since I wrote about this in my blog, that I would write about it again. And so I wrote about it last week. And this is an extremely unscientific poll, but I'm going to share it with you anyway. but you'll see that there has been a shift. And who reads my blog? Probably mostly ID doctors. And so the question, should ID doctors still do primary care? In 2014, 57% said yes. And in 2023, 26% said yes. And there's been a shift. And one thing I did in the piece, which I encourage you to read it, so that way they'll still have me write it for New England Journal of Medicine, is I said, imagine you as an ID doctor were given the option of 2 different state-of-the-art lectures by a great speaker. One is on, advances in invasive fungal infections, which is a fast-moving field, and the other is on advances in management of type 2 diabetes, which is a fast-moving field. Which would you, as an ID doctor, feel is more important for you to get up to date on? And I guess if you're primarily doing HIV primary care, you would choose the latter, but most ID doctors, I think, would probably feel they should get caught up on the invasive fungal infections talk, which is fine. I think we should understand our limitations. I know that my limitation for diabetes ends with metformin, and there's a great deal more out there for people with diabetes now than just metformin. So one way of looking at this is you could look at the model that other specialties have carved out for themselves. And I think oncology and rheumatology are perhaps the best examples because they're managing potentially extremely complex pharmaceuticals, diseases, monitoring, and they take the primary role when these diseases are active. And that's something that case 1, clearly you'd expect an ID doctor to take the primary role. Diabetes may be somewhat less so, but in none of these 3 specialties do we expect these specialists to be responsible for primary care. Now, there is going to be a pushback on any shift. And someone mentioned already the fact that the resources are not necessarily available in general primary care, but I'm going to show you an amazing figure. And this figure was shared with me by someone who I'm not allowed to say who it is, but I'll just tell you, if you look at who is writing prescriptions for antiretroviral agents in the United States right now, this is an asymptotic curve that quickly achieves very high levels. 50% of prescriptions are written by only 1,300 clinicians. 90% are written by 7,000. And then a smattering are written by others. And this includes PrEP. So if you actually looked at the drug, maybe, not a first-line drug, but the drug dolutegravir or darunavir, I think you would find that these numbers are even lower. And then I'm going to summarize some other reasons why HIV primary care might stay in HIV, or there might be some resistance to transferring it over. I've already talked about the first bullet item. The second bullet item is a strange financial reason, which is that some ID primary care have in them embedded 340B pharmacy funds, or that 340B funds go to ID to do this care. Everyone I've spoken to who does primary care says we are overwhelmed. And then this incredible figure, which I absolutely love, which was created by David Serrata from Florida, shows all of the various antiretroviral agents. And even though that is no longer really that complicated, this is the perception. This is the reality. Most people are on one of 2 regimens these days, but there are some exceptions. So anyway, I think we are at the point where we should try to shift some of our primary care to general internal medicine, and it's going to take educating people like Joyce and to be able to do this. So there are a critical role for ID and HIV. I don't in any way want to dismiss it, and I've listed them here. They're all things that you could come up with yourself, but I think some of them really deserve emphasis because there's no way we can ask our people who are general internal medicine to make the decisions on opportunistic infection management or some of these other things. It's like the whole issue of long-acting antiretroviral therapy. It's really kind of tricky, except for the very clear cases where someone's a slam dunk candidate. It's actually put a lot of stress on us again to really carefully review our patients' treatment histories. And then the last one I put in bold because I am hopeful that there will one day be a cure intervention that is like scalable, where you have to do a very complex assessment to see whether your patient's eligible. And that is, of course, the pot of gold at the end of the rainbow. So I think that we all came to the same conclusions about these particular cases. I think the second case is the one that actually ends up being more borderline, this very stable, highly functioning person who doesn't have other medical problems. So they think, well, why should I go to two doctors? On the other hand, if they don't check in periodically with someone who's keeping up with the literature on HIV, they may not hear about all their options. So at the very least, a yearly check-in. But that last case is the one where we really start to feel out of our element. So I want to wrap up now. Someone gave me wise advice when I was first starting to teach and says, never go over, always finish early. They will thank you. So I'm going to finish early. I'm going to just say that ID expertise is still critical to HIV care. For HIV primary care in stable patients, experience and interest are more important than degree or specialty. And what we need is someone to do a study today in our current amazing treatment era. And I'm going to thank a bunch of people who gave me input on this, including an old friend of Eileen's, our incredibly wise social worker, Susan Larrabee. So happy to take any questions or comments.
You convinced me.
Hi, can I talk? Hi, Dr. Sachs, that was wonderful. And I read your blog and I had a reaction to that. I was reading it because I think it's very hard to untangle the infrastructure that a lot of our HIV clinical programs has because of Ryan White funding and the care coordination that has really been emphasized over the last 30 years. It is the reason why patients do better and are more virally suppressed when they are being managed by a clinic or a practice that has Ryan White funding. And I think it's very hard to look at this question about who should care for that individual, no matter what spectrum. I would say all of those patients in a certain situation would be better cared for in a practice that has this comprehensive care that has totally been funded by Ryan White. And that's the hardest part for me personally to disentangle, that this funding is so important to provide not just HIV management,
Yep.
but we have been able to bring in a lot of subspecialties, like Joyce has brought in geriatric care. We've had nephrology, we had GI, we've had nephrology, we've had mental health services and psychiatric services in our program since 1990, really since we got Ryan White funding. So that's when this is brought up, I feel it's very hard to figure out what would be best. And even in our own clinical practice, because we have our main practice in Bartlett, but we have a county program, we have what I would say more private care practice that is over at Green Spring Station. And when those patients, for whatever reason, if they lose their insurance or they just need more additional support, they're brought into the Bartlett because that's where everything is. And anyway, I think it's very hard to move forward and think that we could send our elderly, complicated patients to be managed just by and just see them once a year.
Excellent point. I would never argue that we should defund the Ryan White programs. They're really critical. It's more really about infectious, ID specialists. It's kind of the really the tension I'm feeling myself.
And Paul, I'll just mention that Jeannie ran our Ryan White program for many years, so has like very intimate knowledge of this. We have 3 other people who want to talk, and I'm just going to ask, as you listen to their other questions, to weave into this how we train ID physicians as if there isn't, like, if there is a divorcing of this, because as we all know, HIV is now an outpatient disease, and how to that next generation of fellows and physicians in ID and their training. But I think Jean had her hand up, and then Laura, to you.
So hi, full disclosure, I am one of the specialty practitioners in the Bartlett Clinic for GYN, so I'm either ID or internal medicine. However, I do run the women's HIV program. So like Jeannie, I've been in that Ryan White world for a long time, and I ditto most of everything she said. But I did want to add one other point. I think HIV is a little bit different because of its public health situation, in that and we do know that people who have those wraparound services, but usually from Ryan White, have higher viral suppression rates. And then when you compare that to populations that are not in the Ryan White, and please forgive me if I'm saying this incorrectly, anybody, but I'm pretty sure that they have lower suppression rates. So I think we have to keep that in mind as well. The other thing to think about is our patients. And I think they love having this, and we do have an underserved population, so it's different than maybe some other populations, but they love having a patient home. They love that I come to them to provide reproductive health services, and that I can provide that care there in a place where they're comfortable.
Yeah.
So I think, again, maybe because I've been doing this a long time too, I just feel like, it's our baby. So just wanted to make those few comments. And again, everything everybody already said, I ditto.
Good point.
Yeah, so this is Laura, and I'm remarkably won't say a lot about the Ryan White program, but I was just except that, when you talk about getting care, you don't get care in medical care anymore in this country, most places, in most primary care places, but you do get care in Ryan White program. So I'll just say that. But and I think Jeannie was getting to some of that in terms of like that need to follow up and having outreach workers and all of that available. But I think, so what you're talking about here, which is obviously very important among people that are in care, but if you think that there are 250,000 people not in care in this country, as well as probably 150,000 that need to get diagnosed, but 250,000 that know they have HIV and not in care. The other group is, so I do agree on this discussion, primary care ID, I understand that's the issue here, but I think there's a broader issue about like, what are the models of care that are actually going to work to really engage people in care that are but not remaining in care over time. So how do we really better use street medicine, or like, what are the, like, I don't know what the data are actually about street medicine, but like, what are those models of care to actually engage people that are most in need of care who aren't currently receiving it because of our models? And I think, so I appreciated this comment. I just want to take that kind of to a slightly different level.
Yeah, that's a great question. I wish I had the answer. I mean, we all struggle with this group who are diagnosed and not in care. And so I don't know how many of you know the Boston area, but I have several of the people who meet that criteria in our clinical program often live in Brockton, and they say that they won't go to care in Brockton, where there is a Ryan White funded clinic, because they just feel horrible stigma associated, but they also aren't coming to Boston. And it's really it's very difficult. It's not that long a drive. It's about a 30 to 40 minute drive, but it's just a very, very challenging thing to engage them.
Amita, I think you were next.
Yeah, great. Thanks, Paul, for really a fantastic talk. And really, I think the debate continues clearly. But, it's interesting. I'm wearing this white jacket today because I'm on our inpatient HIV service. We still have one of those. And I think that, last week we had 11 patients who had their CD4 below 200 without detectable viral load. So and as Monica Gandhi, who talked recently, said, 10% of people have 90% of the virus, and Laura just mentioned that. So I'm interested in your thoughts about these inpatient HIV services versus the general consult approach to taking care of HIV and the inpatients accessing, knowing that really what we need is these wraparound services. And I can speak a little bit of what Joyce and Jeannie and others have created, which is to really bring the outpatient folks to come to the inpatient to link them to care, which is incredibly important. But our inpatient services evolved where we've lost some of that case management cohesion and social work cohesion because we're split in different floors. And I think that was what was the beauty of our interdisciplinary care in the inpatient side with the ID physicians and others. We have general internists also doing the inpatient HIV. But I'm just curious from your perspective with your surveys, how many places have this type of model?
Very few.
Very few, right? And whether there's really any way to think about this being a way to engage that bridge to getting the folks who are most hard to reach, who are coming in for hospital care and getting them into specialty care. So
gosh, that's a great question. I mean, aside from your unit and the one at Grady in Atlanta, there are really not many left. You know, I know that I think Yale still had one as of a few years ago, but most academic medical centers have not maintained their dedicated HIV inpatient units. We get a list every day of all the people with HIV admitted to the Brigham, and one of the jobs of the HIV fellow is to scan their reasons for admission. And you know, most of the time they're being admitted these days for non-HIV related reasons, and they actually don't need ID consults. You know, if they're getting admitted for an elective hip replacement, then they're just getting an elective hip replacement. But a small fraction of them are still in the category that you described with unsuppressed viral loads and low CD4 cell counts. So, you know, it's a very, very interesting question. I think that one thing that's been brought up repeatedly in this discussion section is the importance of wraparound services. And that's something that most primary care practices can't offer. And so this Ryan White funding is absolutely critical. We have a little bit of Ryan White funding, but we have mostly as hospital funding to coordinate the care of our Brigham patients. And that funding is absolutely so important. Yeah, so.
And Paul, correct me on this, but that funding was because you were able to demonstrate that it was more costly not to do it.
Okay,
right?
we basically, in the early 90s, our hospital was getting creamed with long hospitalizations of AIDS patients, people with AIDS who were basically staying here forever.
Yeah.
And it was shown that if they actually had a dedicated team taking care of them, especially social work, then we could do the follow-up. You know, we can get them out of the hospital and do their follow-up. And so we've never lost it, thank goodness, because we still do we do essentially all the care for the hospital's patients with that funding.
I don't want to have the last word, so Paul, please speak after I talk. But just a couple of things also. I think the stigma around HIV, right? Homophobia, just the having an HIV diagnosis is different than having cancer. It's different than having diabetes. And so I think the model of care piece is very important. Who are the people who are seeing the patients? What's their training, both in terms of treating HIV, but also in terms of caring for this patient population? Those are very important things to consider. If we think that HIV primary care should be done by generalists, internists more, then we need to create training opportunities for that. ID has always been the natural place of training, so being thoughtful about that. And then also just for research, I don't want ID colleagues to go away because there are still a lot of important questions to be answered. And if those folks don't have that clinical experience, the research will not be as good. So those are just the last few things that I'm thinking of.
I think that excellent point. And I want to say that Amanda Rosencrantz also made an excellent point in her chat. And the last point about research is that we still, fortunately, are able to attract some people in ID who are very interested in HIV medicine because of the research questions, because there are still some really fascinating research questions. And, you know, that cure one alone and the immunology alone is enough to drive lots of advances in the field. Anyway, thank you for your comments.
Well, I'm very mindful of the time, and Paul doesn't ever go over. He's like Tony Fauci like that. But so we are at 1:01. So thank you so much, Paul. It's
Thanks,
really
Eileen.
so fun to have you here. And thanks everyone as we think about the future of the care we deliver.
Okay, thanks, Eileen. It was great to see you.
Have a
Bye.
great weekend, everyone.